Hello, and welcome to Hospice Insights, the Law and Beyond, where we connect you to what matters in the ever-changing world of hospice and palliative care.
Heed caution, takeaways from the OIG's Advanced Care Planning Report. Andrew, Zaina, welcome. So glad to be here with you.
Thank you. Yes, so happy to be here.
Hi, Meg. Thanks for having us.
Andrew, let's start out talking about sort of big picture on this Advanced Care Planning Report. I know when I read it, I wasn't necessarily surprised at some of the things that they talked about, but I think, they, as usual, they're finding that there are some errors and the documentation doesn't match up with what they want to see. But there was some interesting sort of back and forth between CMS and OIG in this report that I want to talk about. But let's start with sort of the nuts and bolts here. What were the findings of the report about advanced care planning? Were people doing it right or wrong?
Well, according to the OIG, people generally were doing it wrong. So the OIG looked at a sample of about 700 advanced care planning services that were billed, and they looked at two specific CPT codes. And the kind of headline finding is that for 2/3 of those visits, the OIG did not find that the documentation was sufficient and that the providers did not comply with the advanced care planning billing requirements. That the kind of documentation issues that the OIG pointed out, a lot of them had to do with concurrent services. So the OIG would have been looking at a visit for advanced care planning where there was another either time-based or disservice-based service that was included within that visit, but the provider did not separately document the concurrent service from the advanced care planning. So that was an issue. There were some issues just with, the documentation not even referencing the advanced care planning or the provider not even having documentation, which are sort of obvious issues.
So I had some deja vu when I read this because it made me think about the report from, it's probably 7 or 8 years ago. And we'll include a link to this current report about advanced care planning and then the report from a number of years ago about E&M codes and the high error rates, like 80+% that the OIG found in that documentation as well, which is slightly different issues. But, are you really showing what it is you're doing? Like for E&M codes, you have to, and now the rules have changed a bit, but have you reviewed all these systems? How much time have you spent? All these different things, and seeing that the documentation doesn't necessarily align with the code. But I guess why I wanted to do a podcast on this was, I think physician billing in general, I think, is under scrutiny in a lot of different ways. And I think that the advanced care planning codes in particular for hospice, to the extent our practitioners use these codes in our palliative care programs or in hospice, this is something we need to be attuned to because other auditors could be picking up on these same findings or bring further attention to them. So I think it was really interesting. Now, maybe even the thing that was most interesting in this report was CMS's response to some of the things that OIG said, which again reminded me somewhat of this E&M code report, where it's not that they disagreed necessarily with the findings, but they didn't seem overly concerned. And then in particular, Andrew, OIG said, hey, we found that a number of beneficiaries got multiple advanced care planning codes. I think they bring up the example, a patient got 15 different advanced care planning visits. What was CMS's response to that?
Well, just like you said, they kind of poured some cold water on that. CMS doesn't seem like they're really interested in putting limits on just like the aggregate number of advanced care planning services. that can be billed to a given beneficiary, which was sort of what I think the OIG was suggesting to kind of safeguard against those kind of outlier cases where we have like 15 or 16 services for the same patient. So CMS did not seem to like that idea. Now they did say that if you have multiple advanced care planning services for the same patient, they do want to see a documented change in the beneficiary status, end of life care wishes, or both. But to your point, not interested in actually imposing like a cap on the number of services.
Which I think was really important because they're not trying to step into the relationship between a physician and their patient and making medical decisions about, what's medically appropriate. But I think heeding caution, though, have more substantial documentation. So doing an advanced care planning visit every single month. And even if you document it, but it looks just like the documentation before, it's probably going to lead to the same result as a denial, not because you exceeded some predetermined cap, but more because your documentation doesn't support the need. But Zaina, let's turn to you for a second, because I read this report and was thinking about all of the physician billing denials we're seeing in our hospice audits. And in particular, when there's concurrent face-to-face visit and also a medically necessary visit, we've been seeing a lot of denials around that. And so while this isn't advanced care planning, this idea about if you're doing an advanced care planning as part of your visit, and then the other part of your visit is doing something else, you need to make sure that you're separating and accounting for your time. And that's exactly what we're seeing the government do as it relates to face-to-face visits, is how are you accounting for the face-to-face visit portion versus if you're billing for a medically necessary portion. So elaborate on that a little bit of what you're seeing, Zaina.
Sure. So face-to-face visits are not separately billable, but concurrent services may be if, as Andrew stated, they're properly documented. And reviewers sometimes allege that physician visits aren't separately billable if they occur concurrently with a required face-to-face visit, but they are separately billable if they provide reasonable and necessary non-administrative patient care. So hospices can appropriately bill for any non-administrative portion of these services or any care that's really above and beyond what would typically be provided in a required face-to-face visit. For example, physician visits are separately billable if they involve medical decision-making that's not administrative or supervisory in nature. And the technical denials that arise from the physician visits that occur concurrently with administrative face-to-face visits are really rooted in a lack of proper documentation that's analogous to the documentation issues for advanced care planning addressed by the OIG and summarized by Andrew earlier.
In the past, we saw when auditors, so UPICs, MACs, whatever, they look at our documentation, they would look to see, is there a physician visit that correlates on the claim form? You billed this, is there a visit note? That's like the olden days now. And if you had a visit note, then it was like, okay. But now I think they're looking more deeply at that and looking at, well, you billed this code. Is that really supported by your documentation? Sort of like a traditional Part B review, where is this supporting the C&M code? I think the thing that's most often coming up is exactly what you said, Zaina, is a lot of the physician visits that are getting denied have a face-to-face component to them. And then, there isn't a way that you can easily see the difference between the face-to-face portion. So it looks like you're billing for the physician visit, even though I don't think that that's what people are, intending to do. So I think best practice really is having separate documentation for your face-to-face visit from any billable service you may provide to make that crystal clear. I mean, CMS has not said that's absolutely required, but it's the easiest way to sort of meet the standard as opposed to having one consolidated note. Even if you split it into two chunks, I just think it's easier. But anyway, so I guess any closing thoughts, Andrew, from you on this?
Well, just in terms of talking, you mentioned kind of selecting the right E&M code to describe the visit that you're billing. In the OIG report, the OIG seems to go out of its way to describe, sort of how to calculate units of time. So, it seems like maybe providers weren't doing that in the sampled claims that they looked at, but essentially, if like a given E&M service, says that it needs to be between 0 and 30 minutes in length, you can only bill that if you reach the midway point. So essentially, you have to have one more than half. In that case, it would be 16. So you can really only bill that service if you have, in that example, 16 minutes. So I think that's important to remember.
Sounds a lot like our lives of billing time.
Yeah.
Is that 14 minutes or is that 16 minutes?
Yes. Yeah.
It just, which it's frustrating. And so I think we can have some affinity for physicians who roll their eyes at some of this, like, oh, geez, you're keeping 16 minutes. I got to keep track of that. But I think you're exactly right. Really important.
Yeah. And I guess the other, thing I noticed, I guess, is that the OIG in a couple different places referenced that they thought that this report constituted credible information of a potential overpayment. So if you see those words, that's sort of an allusion to the 60-day repayment rule, because credible information of a potential overpayment is the trigger for either making a repayment under that rule or doing a reasonable diligence investigation to determine if there in fact was an overpayment. So I think all the more reason to maybe take a look at your current documentation practices for E&M codes in particular, and just make sure that you're separating concurrent services, separately documenting them, and then, calculating the time correctly.
I think that's exactly right. And I think in general, hospice and palliative care programs have spent more time with educating physician on billing and doing, as part of their compliance plan, bringing an outside consultant to review. I just think that this is, we're going to post the report from a number of years ago where it's E&M codes have, 80+% error rate in them. I mean, this is always going to be low hanging fruit. And this report is sort of just adding to the mix, which, I think folks can get education fatigue, right? Where people are just like, are you telling me I'm doing everything wrong all the time? And like, I need to spend more time documenting. So I think we got to be cautious of that so people can really hear the message. But I think there are, as you said, some pretty simple ways that I think, obviously, people who have no documentation, that's not good. But I think this whole idea of how do we provide tools to help people keep track of their time and also know the rules, right? People went to medical school, they didn't go to coding school, right? I think that there is training on that, but as hospices get further upstream and look to further expand their palliative care programs, this is going to be more important than ever if that gets bigger chunk of the pie. Because right now, physician billing is such a small portion of what I think hospice and palliative care providers bill. But advanced care planning is something that I know our clients do bill for. So really relevant report. Any closing thoughts from you, Zaina?
No, I would just echo what you and Andrew have said. Those 3 ways that hospices and other providers are not complying with billing requirements, no documentation or no documentation of the concurrent service or the advanced care planning discussion. And as I discussed, that carries across other areas of hospice as well. So something to keep in mind and maybe adjust moving forward if you're not already doing those things.
Yep. Well, interesting report nonetheless. And it's good to know that CMS can sometimes take a contrary position from OIG. You don't see it very often, but I think it's important that they didn't want to be prescriptive when it comes to providing medical care to beneficiaries. So anyway, well, thanks so much for your time. And So appreciate both of you, and thanks for sharing your wisdom on this call. And thank you, listeners, for being loyal listeners, or if you're new to finding us, thanks for giving us a listen, and hope that you follow and subscribe. And then we release every 2 weeks. So see you next time.
Well, that's it for today's episode of Hospice Insights, The Law and Beyond. Thank you for joining the conversation. To subscribe to our podcast, visit our website at hushblackwell.com or sign up wherever you get your podcasts. Until next time, may the wind be at your back.